For decades, we've been told that antidepressants are the answer to managing depression, that these are effective treatments backed by the science. But what if the research behind these medications isn't as solid as it seems? As a board-certified psychiatrist and former FDA medical officer, I have seen how antidepressant trials are run, and I'm convinced the story that we've been told is incomplete and maybe even a little bit misleading. And so in today's video, we're going to dig into what it really means to call a drug effective for depression. We're going to be pulling back the curtains on how these drugs are studied, uncovering the hidden flaws in the research, and challenging the idea of effectiveness you've always heard about. And I think the truth will surprise you. Now, I think a good place to start this story is by talking about how I was trained when I was in medical school. Back then, I believed everything I was told about antidepressants, just like most doctors do. In medical school and during my training, I was taught that depression was caused by a chemical problem in the brain, and that the fix were antidepressants, and they were supposed to correct those imbalances. And at the time, it all made sense. We were told the drugs were safe and that the science proved they work. And we didn't question it because, well, it was presented as fact. My professors, textbooks, and other doctors all believed it, and so naturally, I believed it too. But over time, I began to notice that things really weren't quite adding up, and small details didn't fit, and I started to question what I was being taught. Fast forward now to residency, and I'm a training psychiatrist, and at this point, I've been prescribing antidepressants for several years, and I was realizing that not all of my patients were getting better. In fact, some were even getting worse, and they didn't like how the medications made them feel. Others found the meds helpful at first, but soon they ended up needing higher and higher doses to keep working. Some of them even ended up gradually needing multiple medications to just feel stable. And when I spoke to my more experienced colleagues about my concerns about the effectiveness of these drugs, they essentially said, don't worry about it. They're proven to be safe and effective, or the reason that they're not working is that the person has an underlying illness that's very severe. And I kept on thinking that I was missing something. Could people's bodies be getting used to the drugs? And could they be needing higher doses because of that? And so I started to dig into the research, and I discovered that there were a lot of psychiatrists out there questioning just how effective these drugs really were. And their analyses were showing something quite different. They were showing that these drugs weren't fixing the causes of depression. Instead, they were causing drug effects, like making people feel numb or more energetic, and that these drug effects were simply covering up the symptoms people were experiencing without getting to the root problem. And this really shook me because it started to make me question everything that I had been taught about antidepressants. So not knowing who to believe, my professors on one hand, and then these other psychiatrists who were questioning the research, I realized that I really needed to understand the research for myself, and I couldn't rely on what I'd been taught. And so after finishing my training, I decided to learn everything I could about how these drugs are studied and approved. I took a special training position with Johnson & Johnson, and I worked on developing antidepressant treatments for depression. And then afterwards, I joined the FDA in the Division of Psychiatry Products, where I had the opportunity to review all of the clinical trials happening in the US. And it was through these experiences that I was really able to understand how these drugs were studied and how we end up determining if something really is effective. At the time, I thought this journey would help me understand things better. But what I found was even more troubling than I expected. Because as you see, once I was working inside drug companies and the FDA, I saw how psychiatric research was really done. I expected to see careful science behind everything that I had been taught. But that's not what I saw. In fact, what I saw raised even more questions. And that's what we're going to talk about for the rest of this video. How these studies on antidepressants are actually done and what they really show. So let's dive in and talk about antidepressant clinical trials. So antidepressant clinical trials are really important in understanding how these drugs work in the short term and in the long term for treating major depressive disorder. And there are two types of studies. There's the short-term registration studies. These are 8 to 12 weeks long, and these are the studies that get the drug on the market. And then we have long-term studies called relapse prevention studies. And these are the studies that allow drug companies to market antidepressants for long-term use. But are these studies really designed to show those things? That's what we're going to find out now. So let's start with these short-term studies. Here's how they work. First, you need to pick a patient population. So the first step is you need to pick patients with depression. And so researchers, they'll get a group of people, they'll use the DSM, and they'll diagnose them with major depressive disorder. For the purpose of this example, let's say a researcher finds 100 people with depression. The next step is they're going to assign them to random groups. And so what that means is one group is going to get the drug, and the other group is going to get something called a placebo or a fake pill. And they usually do this in an even split. So in this example, there would be 50 people who would go on and get the antidepressant and 50 people who would go and get the fake pill or the placebo. Now, these studies, they go up to around 12 weeks duration. And during that time, on a week-to-week basis, the researchers are checking in with the patients to see what side effects they're reporting and to check the status of their depression. Is it improving or is it worsening? Now, at the end of the 12 weeks, they measure the amount of depression the person has using a scale. Now, the most common scale in depression research is something called the Hamilton Rating Scale for Depression 17. And if at the end of the study, there's a difference between the two groups and it is statistically significant, meaning it doesn't look like it was due to simply chance, it is considered a positive study and is considered supportive of the drug working in depression. And what these studies typically show is that these drugs work just a little and that these differences, while statistically significant, really aren't that big. Now, in general, what these trials typically show is something like what you're seeing on this graphic here. So what you're seeing here are results from an antidepressant clinical trial. This line with these white triangles on it is the placebo, and then these darker lines here all represent different antidepressants like duloxetine and paroxetine. And this image is typical for what we see in these antidepressant clinical trials, that both groups improve a lot, but at the end, the difference between the placebo group and the group on drug is very, very small. And we're going to pick up on that point when we talk about the first criticisms of this study now. So the first problem with these studies is that the effect really isn't that big. On average, when they've grouped all of these studies together to see how much of a difference they make, they don't really make that much of a difference. In fact, on average, the antidepressants reduce depression by 1.8 points on the Hamilton scale compared to placebo. So that's a 1.8 difference on a scale from 0 to 52. That's not a huge change. And in fact, some researchers like Irving Kirsch have argued that this improvement may not even be large enough to make a real difference in people's lives. In fact, we've had groups like the National Institute for Healthcare and Excellence in the UK say things like a 3-point difference is really the minimum needed to be considered helpful. And when we look at large analyses of how these drugs perform in depressed patients, the only group that comes close to that are the groups of patients with the severest depression. But for the majority of people with depression, these findings suggest that these drugs simply aren't doing that much. And to make matters worse, the second criticism is that that small change may not even be due to the drug. In fact, it could be due to something called the placebo response. Now, for those of you who aren't familiar with the placebo effect, essentially what it is, it's when a group of people will simply feel better because they believe they're receiving a treatment that benefits them. So here's how this works in antidepressant clinical trials and why people are worried that it's making antidepressants seem more effective than they are, even though the improvement is minuscule, as we've seen. So when someone joins a study, they know they're either going to get an antidepressant or a placebo, the fake pill. And if they start feeling side effects from the drug or the antidepressant, they are going to guess that they're on the active medication. And this can make them feel more hopeful or confident that the drug will work. And this in turn can improve their mood. On the other hand, if someone gets a pill and they don't feel any side effects at all, they're going to expect that they've been given the fake pill, and that's going to make them think that the treatment isn't working as well. Because of these beliefs, either feeling better because they think they're on the real drug or feeling worse because they think they're on the placebo, can actually inflate the differences between two groups in the study. And critics of antidepressants say that when you take these effects into account, this small difference that they found may all but erase the benefits that the active medication has over the fake pill for all patients, even those with severe depressions. So many people have interpreted this to think, well, could these drugs be no more useful than sugar pills? Now, as critical as I am of psychiatry and the way we practice this, I do have to offer a rebuttal here. I don't think this is correct. These medications certainly are not sugar pills. As someone who has taken antidepressants personally and now used them with patients for over 10 years, what I've noticed is that these drugs definitely have a noticeable effect that you could not get from a sugar pill. So why do these studies make it look like these drugs barely work? Well, the answer is that antidepressants really aren't antidepressants in the way we think. And when I say that, I mean they are not fixing the root cause of depression. Now, I understand what depression is a very complicated topic, and that's why we've made a whole video going over what depression is and what causes it. And you can check it out here if you want to understand that before going further. But for the sake of staying on track, Essentially, there is no proof of any unified underlying biological cause of depression that any of these antidepressants could even act on. Instead, what these medications are simply drugs that can make you feel either numb, or they can help you sleep, or they can give you more energy. And these drug effects can help with many of the symptoms that people feel when they're depressed. And so the reason these changes look so small in these clinical trials is that these scales aren't measuring the actual effect of these drugs. Remember, when I introduced the design of these studies before and I told you about the HAM-D, it's important to remember that these are scales designed to measure symptoms of depression, not what the drug is actually doing. And if we look at these scales, it's quite obvious that they're not measuring what the drug is doing. So at the risk of getting into the weeds a little bit, I do think it's important that we look at these scales, because if you really want to understand what FDA and pharma means when they say the drug is effective, it's very important that you understand the scale that they're using to make this determination. So let's check it out. So here is the famous HAM-D. This is the most used scale in antidepressant and depression research. And so let's go through some of these questions and have a think about how we might imagine the drug effects from antidepressants to affect the scoring on this scale. So depressed mood, could an antidepressant fix that? Yes, these drugs can make people feel less anxious. They can make people feel a bit more energetic. It can help with feelings of guilt if it makes people feel less anxious. And then we've got things like suicide. For sure, the drug could reduce feelings of suicide if it's having a calming effect. Now, sometimes these drugs have agitating effects that might actually increase some of the suicidal feelings people are having. There's a whole list of questions here now on insomnia. Some of these medications, especially like mirtazapine, can actually help people sleep with work and activities. For sure, these medications may help with that if someone is having a lot of anxiety or they're really low energy, and the effect of the drug is improving those. If we look at number 8 for psychomotor retardation, now if someone's having an energizing effect to that drug, that could improve that scale. But a lot of these medications can actually make people feel kind of blunted and disconnected. And if it made you feel like that, the effect would go in the opposite way. That's the same with agitation. Sometimes these medications make people feel agitated. Sometimes they make them calm. Coming down to somatic symptoms here, antidepressants could actually make this worse. A lot of antidepressants can cause things like butterflies, indigestion, or stomach cramps, or diarrhea. And so now you could see the drug effect actually making it look like someone is having a higher score of depression. Again, with the gastrointestinal symptoms, some of these drugs can lower appetite, so it could make someone score as having a higher amount of depression if they had that side effect. And then even going down here to the genital symptoms, a lot of the SSRI medications actually cause sexual dysfunction. And so by taking them, they might actually now score higher on this depression rating scale. Moving on to the last couple of questions, if we look at hypochondriasis, now you might debate whether hypochondriasis should even be a symptom of depression. I don't think it should, but an antidepressant effect, if it caused lower anxiety, it could make someone look less depressed on this scale. If we move on and we look at loss of weight, some of these medications help people lose weight, but some of them make people gain weight. And so an SSRI might have someone gaining weight and making them look less depressed. But something like Wellbutrin that's appetite suppressing could make someone look more depressed on this scale. And finally, the funniest one of all is insight. Apparently, if you believe that your depression is caused by bad food, climate, overwork, or a virus, you're actually counted as being more depressed. And so there actually are just some very questionable things about this scale in general. But for whatever reason, this is the one that psychiatrists have chosen to use to represent what we think of as depression in clinical trials. So what I really hope this exercise made clear is that these studies really aren't looking at what the drugs do globally. They're looking at how the drug effects just changes various scores on a depression questionnaire, which I may say seems quite questionable and outdated. And so I want to do a thought experiment for a moment, because I think it's important to just think about what you would actually do if you wanted to run a study where you would actually measure what the drugs do globally. Well, here's how you design it. You would give the drug to 100 people, and then you would ask them to describe how they felt. You would listen to all of them. And then some people would say they felt anxious. Some people would say they felt calm. Some people would say they slept better. And you would collect all of these things, and then you would build a questionnaire around what they reported. For instance, if we were looking at an SSRI like Prozac, you'd probably end up with a questionnaire that looked something like this. It's likely you'd have a question about people feeling calmer, a question about people feeling less anxious, some about people feeling a bit energized, some about people feeling restless, some people feeling flat, and some questions about people feeling somewhat dulled. Now, this is just a hypothetical example that I've put together quickly because these are all of the things that I've heard people say over the last 10 years when I've given them SSRIs. And the truth is, there's a lot of variation in how these drugs work on people. Some people feel calm on SSRIs, while some people feel anxious and energized. And so if we actually use scales like these in these studies to supplement, in addition to the depression rating scales like Hamilton, these scales would actually show very large differences between drug and placebo, because these drugs are certainly not sugar pills. They actually have quite large psychological effects. Now, unfortunately, scales like this that actually measure the drug effects have never been conducted, which is hugely disappointing, because what that means is we can't perform any analyses on groups of people who have these different psychological responses to the drugs. For instance, if we did use scales like these, we'd be able to look at maybe groups of genes that predisposed people to having a more numbing response. We'd be able to look at maybe ages where, certain age groups are more predisposed to feeling restless. And we could also look at how your liver and your kidneys metabolize these drugs and whether slow metabolizers might end up feeling more flat and dulled on these medications. And I simply think it's crazy that the FDA hasn't done this, that academics haven't done this, and that pharmaceutical companies haven't done this, because this information would be so important and so helpful in helping clinicians work with patients. But because I've worked at the FDA and I've worked in the pharmaceutical industry, I actually believe there's reasons that this hasn't been studied in this way. And forgive me in advance, some of these are quite cynical. We're going to start with the very plain one first. So the very plain reason why we don't study antidepressants in a way where we actually study what the whole drug effect is and we just look at them for depression is because of the FDA. In order to get a license to market the drug and sell it to people, you have to show that the drug works on a specific condition. If you studied the drug globally, you wouldn't be studying it for a specific condition. And so because of that, pharmaceutical companies simply don't invest in that kind of research because it doesn't lead to a drug approval. The next reason why I think people don't do this is that there's a lot of researchers out there who I think still believe that antidepressants fix depression like some vitamin fixing a chemical imbalance, and they've just swallowed this narrative hook, line, and sinker. And I think this is a total crisis of intellectual curiosity to miss out on this whole area of research. And what I think is quite obvious, that these drugs are actually helping people because they have drug effects. The cynical reason that I think this type of research isn't done is because drug companies and leaders in psychiatrists, they kind of don't want to admit that these drugs work by changing how you feel and not fixing an underlying problem. For moral reasons, I think drug companies and some senior psychiatrists see it as a lot better to be positioned as people who are fixing some medical condition than being people who are simply using drugs to kind of mute how people feel. Psychiatrists really don't like being seen in that way because it opens up this whole avenue where it's almost like The One Who Flew Over the Cuckoo's Nest, where all of those nightmare and horror story versions of psychiatrists come out as this group of people who kind of use medications to sedate people who are unhappy because of political things going on, and that they don't really care about understanding the actual reasons why people are unhappy and helping them with the real reasons. They're mostly interested in just sort of masking those with drugs. That's why another reason I don't think a lot of people are interested in this research, because it opens up a whole range of ethical questions about using drugs to suppress unhappiness when there's actually legitimate things that could be causing it. That's kind of disturbing. And so thank you for coming on this brief aside with me. I do think it's important to look at that. And so now let's summarize what we know. Well, here's what I would say. These drugs do appear to be associated with a very small change on depression scales. This is not because they don't do anything. I hope I've made that point clear. It's because they're simply not very good antidepressants at changing those scores on that depression scale. These are simply drugs with a combination of numbing, sedating, or energizing effects, which are kind of varied. And so now that we've covered what the short-term studies show in terms of effectiveness, let's now turn our attention to these relapse prevention studies. Now remember, these are the studies that the FDA and the pharmaceutical companies use to determine whether these drugs are effective for long-term use. So let's go. Okay. So in psychiatry, the way we decide whether a drug works long-term is with something called a relapse prevention study. Now, I want to make clear, and you're going to see this as we go through this, this is very different from just having that double-blind placebo-controlled study that we looked at in the short-term study and just making it much longer So you could see what it does over a year or 2 years. It's very different for that. So I want to describe to you how these relapse prevention studies are designed. The first thing that you do is you get a group of people and you put all of them on the medication. There's no placebo group right now. It's just a big group of people getting antidepressants. You then follow these people for 3 months, and then out of that whole group, you get all of the people who improved or got completely better. Now, out of that group, you then split them into 2 different groups. One group keeps on taking the antidepressant, but the other group is switched to a placebo or a fake pill. Now, the way this switching to the fake pill is important, and typically what happens in these studies is they're either immediately switched, i.e. there's no taper, or they're tapered over a period of 2 weeks. Now, neither the patients or the researchers know who's going to go into those 2 different groups. After that happens, the researchers will then follow those 2 different groups for 1 to 2 years. And what they're looking for is to see whether the group who was put on the fake pill are getting depressed at a higher rate than the group who was continued on the active medication. And so that's the main result. They're looking at the percentage of people who relapse or become depressed again in the group who got to stay on the medication and the group who was unknowingly put on the fake pill. And here's what these studies generally show. What you're seeing on the screen is something called a Kaplan-Meier curve, which is how they represent this data. What this blue line shows is the number of people who have not relapsed at the end of the year. And so about 55% of people have not relapsed. This is the group on the drug. And what the red line shows is the placebo patients, and it shows the number of people who have not relapsed at the end of the year. And this is around 35. That's generally in line with what people see in these relapse prevention studies, that there seems to be about a 20% less relapse if you are on the drug. And this is seen as proof that these drugs work long term. And because of this, a lot of doctors will prescribe these medications long term to prevent relapse. And if a drug company gets a positive result on a study like this, they can say on the drug's label that this drug prevents relapse, and they get an FDA approval for long-term use. Now, all of this might sound good, but there's actually some big problems with these studies as well. And that's what we're going to be discussing now. So the first issue is the withdrawal problem. Now, the problem is in all of these relapse prevention studies, when they get to that phase where they kind of split them into 2 groups, so remember they had the group of people who did well on the drug and then they put them into the 2 groups. They're not tapering the medication well in the group that goes to the placebo group. In fact, they either do it immediately or they do it over a period of 2 weeks. And because of this, a lot of people are experiencing withdrawal symptoms. It is quite common for someone who has been on an antidepressant medication for 3 months to not be able to simply come off it in 2 weeks without residual withdrawal symptoms. And so the reality is a lot of these people who are quote unquote relapsing in these studies are actually people just experiencing antidepressant withdrawal. And this is a big problem because it makes it look like the people who are in the fake pill group are getting depressed again. And there's a lot of critics out there who will look at this and say, well, because of how quickly they stopped the drug, these studies actually don't prove that these drugs prevent relapse. But again, as much of a critic as I am of psychiatry, I don't think this criticism is entirely right either. Because to me, it just simply makes sense that if someone is doing well on the drug because the drug effect is masking their depression, and if you simply take that drug away, their old symptoms are going to come back. So yes, I do believe for some of these patients, these drugs are suppressing the symptoms, and if you removed it, they're going to relapse. And so I don't believe that criticism is completely founded. But from my perspective, there is a much bigger problem, and that's what I'm going to talk to you about now. This is called the tolerance problem. Because you see, what a lot of people forget is that these neurotransmitters, they're not these like little things that just work on our mood and our emotions. They're actually involved in the entire way that our body works. I'm going to show you a graphic. I don't want you to get overwhelmed by this, but it simply makes the point. So if we look at serotonin, it's involved in the cardiovascular system. It's involved in digestion. It's involved in the immune system. There are so many things that this neurotransmitter is doing, and our body simply doesn't like that. And because our body wants to stay within its normal range of functioning, it sends signals up into the brain to push against the drug and for the neurons to change their structure so they're not being as affected by that drug. Now, this is really important because once you become tolerant to the effect of the drug, essentially the drug has stopped working, and you really have 3 choices. And what I would say is none of them are really good. The first choice is you simply keep increasing the dose to maintain the drug effect. but this often comes with more side effects. And quite frequently, what I see happening is people get maxed out on one dose, and then they start a new medication, then they max out on that one, and so on and so forth. And this is the way that people, once they start taking these medications, just accumulate more and more meds because they're just becoming more tolerant to the drug. Now, the second thing that can happen is that you just leave it alone, but then effectively you're just stuck on a medication that's potentially causing side effects and not really doing anything for you. Now, the third thing you can do is you can try and stop the medication when you become tolerant to it. But this is hard as well, because now not only do you have to deal with the symptoms that you had that made you go on the drug in the first place, on top of that, you're now dealing with the withdrawal symptoms from coming off the drug. Now, because of how these studies are designed, we don't have any data on how tolerance happens. Remember, all these studies show is what happens when you get a group of people and you put them on the drug for 3 months and they respond, and then you randomize one to get the drug ongoing and the other group to essentially withdraw from it. And then you're just looking at who relapses. That is not the type of study that would show you when people start to become tolerant to the drug and the effect wears off. And from my experience as a physician using antidepressants, many people do become tolerant to these effects. In fact, it was very uncommon that someone would come in and see me and I'd put them on 50, I'd put them on a low dose of an antidepressant, and they would just be fine forever. And I wouldn't see them anymore. In fact, the most common scenario is that person would be back in 6 months, 18 months, or at the 2-year mark saying, hey, the effect of this drug has worn off. What next? And in which case, what frequently happens is you just go up on the dose. Now, and that is really important information that I think everyone should know when they get on this medication. It's just how long it takes for that drug effect to disappear because of tolerance. Because like I mentioned before, once you become tolerant, you don't have great options. And so let's do another thought experiment for a minute, and let's think about what we would have to do, how we would actually design a study if we wanted to see when this tolerance kicked in. Essentially, what it would be is much like that short-term study, but longer. You get a group of people with depression, you put 50 of them on a fixed dose of the drug, and you put 50 of them on a placebo. And instead of just stopping the study at 12 weeks like they do, you would follow them for 2 years. And 2 years would be a really good period of time to follow them for, because the median duration of antidepressant use in adults is approximately 2 years. And so we should have this data to guide people. And really what I believe would happen if you did a study like that is that you would show that in the short term, there was a difference between drug and placebo, but then over time, you would see that difference decrease more and more. And the two lines, the drug and placebo line, would essentially approach each other when it came to the amount of depression they were reducing. Because what I see frequently is many people are becoming tolerant to these meds when they take them long term. Unfortunately, we don't have these studies. There's no real good reason why we don't have them. We already do them for other long-term medications like statins. They're like 3 or 4 years. And honestly, antidepressant clinical trial research is not that complicated. And one of the things that really bothered me about the FDA when I was there, and even now kind of looking back on it, is that the FDA hasn't asked companies to do these kinds of studies. I mean, these are multi-billion-dollar companies out there who have the resources to do these things. And when you have so many people on these medications, when I last checked, it was 13% of men and 19% of women were taking antidepressant medications. This is exactly the kind of data that physicians and patients need to make informed choices about whether they want to get on these medications. Okay, so we've covered a lot now. Let's move to a summary. Here are some positive things that I can say about these meds. The drugs, they definitely work, and this means they're not sugar pills. They have real effects, and they can make people feel numb, energetic, or sleep. These can be very therapeutic for some people who are experiencing these things. And most people who take these medications are going to notice those effects. These effects seem to lower symptoms on depression rating scales, but not by much on average. But that said, it's important to remember that we're talking about averages here, meaning that for some people, the drugs are going to do more, and that for some people, they're going to do less. And so there's likely going to be a group of people who are going to have more therapeutic benefit on these meds. And then the last last thing is, if you suddenly stop taking these drugs when they're helping you, it makes sense that you're going to lose the drug effects from them and that your symptoms of depression may come back. Now let's move to the other side and start thinking about some of the uncertainties. These were the things that used to keep me up at night and honestly still do when I think about these antidepressant clinical trials. Well, the first thing is that these studies don't actually tell you how the drug will make you feel. Like I said, these medications can make you feel numb, energetic, or sleepy, depending on which one you take, and then your own individual differences. And none of these studies are designed to measure the actual effects of the drugs and why different people experience different effects. And one of the major problems with how we use these medications is a lot of the times we just tell people that they're antidepressants and people assume they're just going to fix whatever symptoms they're experiencing. But that's not how they work. You need to try and match the effect that the drug is going to cause in that individual with the specific things that they're complaining about. And because there's so much variance in these things, often we end up putting people on medications and they don't like the effect, or the effect makes them worse. And so there's just this randomness in how we use antidepressants. For instance, let's talk about relationship problems, which could be one reason why someone gets depressed. If you were given an SSRI and it made you feel emotionally numb, that might be really bad for you. If the reason you were having relational problems was you were kind of distant and not in tune with your partner, the blunting from these medications could make that worse. But if you were having relationship problems because you were really shy and it was hard to meet people, having a somewhat blunting effect may reduce that social anxiety, and you might actually feel more outgoing and you might be more likely to meet someone. And so knowing how this drug is actually going to make someone feel is hugely important in how you use them. Fortunately, we can't predict that and we don't have that data. Now, coming to the last big uncertainty about taking these meds is that you simply don't know how long the drug is going to work before your body gets used to it. None of the studies they've designed are long enough to see when this effect starts to wane. And honestly, it's so common in clinical practice. Everyone sees this. The drug effect starts to disappear between 6 months and 2 years for a lot of people. And as I said, when that happens, you're between a rock and a hard place. Do you go higher? Do you stay the same and you're just stuck? Or do you go through withdrawal? And it's for that reason that I don't think it's helpful to say that these drugs are effective long-term, because really for a lot of people, they're not. They're effective for like a period of time, and then they have to make these difficult decisions. And so I think it's kind of misleading to tell people that they're effective long-term just based on these relapse prevention studies. I think it's a massive oversight from the FDA and also academic psychiatrists to not demand longer-term trials that would allow us to see when this happens and then to give that information to clinicians and the public so they can make more informed decisions about whether they want to rely on these medications for long-term use. Okay, so there you have it. That is my take on antidepressant research. I really hope you enjoyed this deep dive that we did. My hope is that the walkthrough on the design of these studies has given you context into what the FDA and the drug companies mean when they say these drugs are effective. The hope is that this information helps you make more informed decisions about psych meds. Thank you so much for staying with me to the end, and I look forward to seeing you in future videos. If you're interested in another video that takes a very critical look at what depression really is, you're not going to want to miss this video over here.